My name is Kristen Digwood. I'm a physical therapist in Wilkes-Barre, Pennsylvania. And today we're going to go over a little bit of pelvic floor myofascial trigger point release. We'll go into some techniques. I'll go briefly in the beginning over what they are, where we see them, how they relate to the pelvic floor, some of the common diagnoses we see that we'll typically do trigger point release, myofascial release on. Now, briefly, just kind of give you a little bit of who I am. So I graduated in 1996 from physical therapy school at Misericordia, and I did my DPT in 2006 at the University of Scranton. I've done a variety of settings. So I haven't just my whole career been exclusively in the pelvic realm, which I always encourage new practitioners not to just isolate into pelvic. That also tells other practitioners who really don't have that much experience in the pelvic world that all of their skills that they've learned, done in orthopedics plays into pelvic. So we're not just looking exactly at the pelvic floor all the time. We're not looking just at the urological system, the rectal system. All the other systems impact the pelvic floor. And today we'll be going over a couple of techniques that are not directly internal, meaning we're not going to do like a GYN assessment or a rectal ductal assessment. We're going to do muscles that lead into the pelvic floor and feed into pelvic floor issues. So anybody who's sitting here thinking, boy, all I've ever done was orthopedic physiotherapy or physical therapy, and this is going to be so different. It's not. It's just a different twist on it. It's a different way of thinking sometimes. It's a different focus on the muscles, but they'll impact pelvic floor issues and pelvic floor issues. So a lot of physical therapists who just focus on the pelvic floor for say a decade are taking courses that are more orthopedic based soon, because we know that the hip, the SI, the low back, the knee, the foot, everything plays into the entire body, and it does play into the pelvic floor. So 9 years ago, my husband and I started a practice called Elite Spine and Sports, and we added in 8 years ago what we call Elite Pelvic Rehab. And we've been seeing a wide variety of pelvic diagnoses in our clinic. Right now, we have about 9 practitioners practicing now in the pelvic realm. I was the first one. I would see just all pelvic diagnoses. We really got a huge burst of them. So sometimes I was 12, 13 hours a day in patient care, which made it tough to run the other parts of the business, but I very much enjoyed it and was extremely happy when we were able to get more practitioners. And we will see about 250 visits just in pelvic diagnoses every single week at our practice, which makes up a little less than half of what we see. We see about 600 or so visits a week as a clinic. So but it just gives you some idea of how much opportunity there is and how many patients need our care. A lot of clinics have wait lists for patients. So sometimes if they only have one practitioner doing it, their wait list will grow to 2-3 months wait. And we've always strived to not really have that wait list. We did that through developing and bringing on more practitioners. But if you're somebody who's thinking about getting into the pelvic world, there's great opportunity. There's a lot of patients who need our care. There's a lot of people who go untreated. And some patients will come an hour and a half, 2 hours to see us, which sometimes isn't wonderful for those who have challenges with sitting. So, but they do. So there's a lot of opportunity in that world. I do teach in various institutions. So we have my alma mater, Misericordia University. I wrote their pelvic program and I teach in it. I became certified by the APTA. Boy, we're going on 10 years ago. Every time is just meshing together, but I'm certified. I am a certified lymphatic therapist, which if you've attended the past continuing ed we did online here, you'll know that that plays into the pelvic floor, and we see genital lymphedema and some issues with incontinence and pain that have to do with lymphatic problems. So becomes a valuable tool to have. And we start seeing local patients working on cases with urologists, OBGYN, urogyno, family physicians. And we get a fair amount of people who just come to see us because they've heard from other people. We do a fair amount of marketing. And where I am, we've been doing a lot in educating the physicians on, what we do, how we do it, how it impacts them. And a lot have been very open to it, even though they may not have heard of it much before. Many of them are struggling with patients who have pelvic pain type issues and not knowing what to do with them. So once they run tests, don't find anything, or they do find something, a lot of these patients struggle for years, decades, almost a whole lifetime with the pain problems they're having. And you'll see how trigger points can play into that and how we can help patients get relief. Sometimes we can completely resolve their problem, and other times we can help them do pain management and teach them how to manage their own pain once they leave us and go back out into the world. So we'll jump now into just some common diagnoses in the pelvic world that we see trigger point issues with, so myofascial or trigger point issues. We use this, and this is not an exclusive list that I have here. I was just trying to brainstorm on what are those common patients we'll see that have trigger points that we've seen some relief in when we utilize these tools. What are some of them that may even surprise the patient themselves that they have the trigger points? Urge incontinence. So that's feeling like you have to go to the bathroom more often than in the past. People have to run off to the bathroom. We'll see trigger points. A lot of these patients will present with them inside the pelvic floor sometimes, but also a very common point that I'll be going over today is in the abdomen. So as we kind of look for them in the abdomen, we'll hit that trigger point, and the patient, even though they may have just gone to the bathroom before they entered the treatment room, they'll say, "Oh my gosh, I have to go so badly now. It feels like I have to go badly," when you hit that point. When we relieve off that pressure, they'll say, "Well, I feel a little bit better. I don't think I have to go." That tells us a part of their urge incontinence is coming from this tissue having trigger point in it. And whenever it gets compressed, they feel like they need to go to the bathroom. And these patients will sometimes go to the bathroom every half hour, sometimes even every 20 minutes, which causes a cascade of problems for that person. One being they can barely get through their workday without being interrupted. Another is over time, when they succumb to urge too early, they keep getting urge signals earlier and earlier. We can kind of turn that around through hitting trigger points, getting them to calm down, teaching a patient that, hey, when you have that urge and you think it's inappropriate, meaning I just went 20 minutes ago, I haven't consumed things like coffee or tea or a lot of water, I really shouldn't have to go at this point. One of the tools we give them is reach down into your abdomen area, give it some pressure, try to relieve that. And it really has been life-changing for a lot of our patients. And we'll go over that when we hit my hands-on soon. Mixed incontinence, so that's having urge as well as having accidents. So just as we said, urge will do it. We can get through that part in the mixed incontinence issue, hit trigger points, try to get that to calm down and get them just a better whole quality of life. Constipation, believe it or not, in the pelvic world, we treat a fair amount of constipation. And when people have trigger points or myofascial problems, it will send signals into the rectal area, into the colon, to hold back and not release. So that when somebody tries to go to the bathroom, they're not really releasing well, and they're having problems with constipation. So we'll find that many of these people have trigger points. This one is also a big one for the abdomen. We'll sometimes find them internal rectally or vaginally on a patient. We'll find them in the adductors, sometimes the low back. And it's a causative factor, or it's also playing into the problem they're having. We'll see just the garden variety chronic pelvic pain. So as we had talked about in our last lecture, this is an umbrella term. So basically it means the patient has pain in the pelvic region. We do have to do a little more investigative work when we get that diagnosis. Exactly where is that? Where is it coming from? What is happening? And one piece of the puzzle is often trigger points. So a person will flare up at times. They'll say, I'm having a good 3 days, and all of a sudden, out of nowhere, I flared up. This population, I will see a ton of issues with trigger points. Endometriosis. So endometriosis in itself, we can't necessarily cure that through physical therapy, but we see a ton of this problem in physical therapy. These patients will have a lot of pain issues when they're having a flare up or they're having an increased problem or they've just had surgery for endometriosis. Patients will have a fair amount of pain. They may then develop into constipation, into urgent incontinence. So it just sets off a cascade of problems for people when they have endometriosis. Trigger points become extremely prevalent. In fact, I'm surprised if I ever have a patient who doesn't have them when they have endometriosis. I don't think I've ever had anyone that I can't find trigger points on as part of their problem. So then interstitial cystitis, which was formerly thought as a problem with just the bladder and overactivity of the bladder and irritation of the bladder, we now know that the pelvic floor plays into a lot of people's symptoms, which is a great thing because a lot of these patients don't have a whole lot of answers. They'll find out they have interstitial cystitis. It'll flare up all the time. They'll have a lot of problems with interstitial cystitis. And they'll try medications. Some medications now aren't used as they were used before because they found a lot of side effects. One of them being issues with the lens in their eye. So they tend to avoid those specific medications, but it leaves them without answers. One of the things that we do in therapy is we give them a flare busting plan. And a lot of that is trigger point problems. So when they flare up, their trigger points will flare. They'll have more symptoms, they'll have decreased quality of life. Some of them report, I can't even get out of bed in the morning. I'm in so much discomfort. The population will see this. And it becomes a big part of our plan. It becomes a big part of their plan in order to reduce these symptoms and get them to be better in the end. While we can't necessarily take away the interstitial cystitis, and I get that question all the time, people will say, so you mean to tell me we're curing it? We're not curing that problem, but we're taking away the symptoms of the problem, which in essence, people they wouldn't really mind having it if they didn't have the symptoms that impacted their life. So that's what we do through trigger points. Prostatitis. This has become a hot topic in the last maybe 5 years in the urology community, where they used to think it was an infection, an ongoing infection, and that would cause prostatitis. Sometimes people will be on antibiotics for a year, still have symptoms, come up negative on tests, but still have symptoms. So they would continue with the antibiotics. As everybody here probably knows, being on antibiotics for a full year can cause a lot of other problems, stomach issues, problems with tendons and joint problems, and yet they were still using them. They've now come over to the side of, hey, when people have this, it triggers off a pelvic floor problem. Let's send them to therapy. And we do see a lot of good results with this population. Big part of it are trigger points. So they'll develop trigger points in response to a lot of things. It'll be that they had pain before and now it triggered off a problem with the myofascial. It could be that the stress of it also will play into trigger points. And so we kind of attack these to get their symptoms to resolve. Many people in this population, you'll be very surprised that they'll have this problem for a full year. You'll start on therapy, you'll put trigger point release into it. As time goes on, they'll feel better and better, and they'll be amazed in maybe a few weeks, a month, when they feel so much better, if not 100% better, and they won't need any more medication, and it kind of resolves that problem. And then the last one I have on the list is penetration pain. So people will have to avoid intercourse or they'll have a lot of pain with intercourse. Once we see this, we automatically think a lot about trigger points. So those could be internal, they could be external. I have on one of the slides some of the external muscles that we'll do trigger point release on in the clinic. A lot of the patients, once we resolve those, if they continue to have issues, then we'll go internally, we'll see what's going on. And remember, a lot of what's going on internally, say vaginally or rectally, is just muscle. It's muscle that reacts like any other muscle, like it reacts in your upper back, it reacts in your low back. By getting in there, releasing these trigger points, releasing them over time, and teaching them a new normal, a lot of people overcome this problem. They've got a way to attack it when it happens. They've got a way to calm it down and kind of get their quality of life back. Now, obviously, this isn't just a comprehensive list. So when you're in the clinic and you see somebody with trigger points and they don't fall under these diagnoses, That does not mean that they don't have trigger points or it's not playing into it. I just kind of picked a couple. Um, I would say that maybe in the pelvic world, at least 80% of people should be looked at for trigger points. You probably will find them. By resolving the trigger point, you'll resolve at least a portion of their problem, sometimes all of their problem. So don't get too caught up in what are the diagnoses we talked about. It's really just finding those trigger points and resolving them is what we're more concerned with versus the actual diagnosis that the patient may enter the clinic with. So now I'll get into what is myofascial pelvic pain. So myofascial pelvic pain, sometimes called myofascial pelvic pain syndrome, refers to pain found in the pelvic floor, muscles, and connecting fascia. It could exist alone with no other medical pathology, or it may exist as a precursor to urological, gynecological, colorectal medical conditions, or musculoskeletal neural issues. So it's kind of a fancy way to say patients with other problems may have trigger points that are playing into this problem that they have or into the pain. Others may come in, have no other diagnoses, no other problem, no medical condition, and really their problem is that they have trigger points. That is a really, really fun population to treat, by the way, because we're just dealing with trigger points, which then leads us down the path as if I resolve this trigger point, or if I can get them to manage the trigger points on their own, they kind of completely get better. And they have a plan for when it attacks again. Some of the other diagnoses, like we talked about, I see being one of them. You may resolve the trigger point and then they'll still have some other issues going on that play into their pain that get handled medically. We work as a team with the doctors. We kind of look into some things like bladder irritants that may be triggering them off, stress management that is causing some problems. But both of them are very, very good to attack the trigger points and look for them. It's just realize that just because a person didn't get 100% better, even though you resolve their trigger points, even for some people who've been struggling with these problems for decades, 50% better, 50% management is really life-changing for them. So what are we talking about with myofascial pelvic pain and how does that come into trigger points? So a hallmark diagnostic indicator of myofascial pelvic pain is the presence of myofascial trigger points in the muscles of the pelvic floor and remotely. A number of studies in chronic pelvic pain literature have demonstrated the existence of myofascial trigger points or hypotonic pelvic floor muscles in a variety of medical conditions. So that myofascial pelvic pain, one of the signs of having it is having trigger points. Because we know that there's not really a test that they'll go into their doctor where they'll say, boy, you're positive for myofascial pelvic pain. That just doesn't happen. MRIs, CAT scans, blood tests don't come back positive for myofascial pelvic pain. So people look to you guys as practitioners to find this problem, identify what it is, say, hey, you're positive for myofascial pelvic pain. A lot of my patients are very happy to get something that comes up on some sort of test because they're sick of hearing, you're negative for this, you're negative for that. We ran a CAT scan, we ran an MRI, nothing is showing up. And what they eventually start to hear is nothing is wrong with you, yet they have this awful pain. They have this awful thing going on that plays into their life. And when they come in the clinic and we say, look at, you've got this is exactly presenting what your pain is. We found some trigger points. You probably have some myofascial issues going on. Some of them are very, very happy, and some of them actually have cried because they're finally finding something that's causing their problem. Here, as I put on the slide, it's often overlooked by first-line healthcare practitioners as primary or contributing source of the pain. We'll see this in urgency and frequency, irritable bowel syndrome, interstitial cystitis, painful bladder syndrome, urgent incontinence, constipation, dyspareunia, endometriosis, vulvodynia, coccydynia, pudendal neuralgia, and many, many, many other things. It's much overlooked in the medical community. So when they go to their GYN and their GYN takes a look at them from a different perspective, they're looking for medical causes, they're looking for cancer, they're looking for something that's happening systemically in their system. I said, they'll come up negative. And a fair amount of patients before we were a presence in the area, and there were no practitioners doing that, were basically told to either go off to uh, mental health to get some sort of answers, or, well, this is kind of your new norm. This is, we're not seeing anything. Take some pain medication, muscle relaxers, see if those help. So it's kind of dismissed in the medical community through lack of awareness mostly. I don't think it's that most of the doctors didn't believe that it existed. I think it was just they didn't have the awareness. Really, they ran out of options and tools for diagnostics, which leads them into not having really a treatment option for the patient. Sometimes they'll be told, I have nothing really more to offer you on this problem. And then they're released out of care from the doctor. So when we talk about trigger points, these first were coined in 1942 by Simmons and Travell, who identified that two different types do exist, active and latent. They found that repetitive motions lead to muscles that are too tight or over lengthened. So in the pelvic world, we'll think about it as repetitively straining when you're having a bowel movement. When you do that, you overtax the pelvic floor, over lengthen the pelvic floor, and could see trigger points. Could also be caused by trauma, fall on the coccyx, childbirth, mechanical, organic stressors, labral tears, endometriosis. If you look into now trigger points and you look into the work of Simmons and Travell, you will see a backlash. I always like to tell people that, because anything that then gets accepted in the medical community and gets seen as working and true, we tend to see a backlash on. And much of the backlash is it really what they thought it was? Are there mechanical stressors in there? What is actually going on? However, I will tell you that as you go through courses and you look into it and you practice into it, we do know that something is going on there and something is relieved through the techniques. So I try not to get too caught up on whether they're saying, oh, it's this chemical reaction or that chemical reaction, because you'll see a lot of back and forth on that. In fact, I've gone to courses where they spend too much time with the practitioners debating for 30 minutes, an hour, what is going on, what do they think is going on. Well, that's all very good on an academic level. Sometimes we just have to get in, use what works, not worry too much about what the underlying factor is, but know that there are trigger point charts. There are patients who have very much been appreciative when we find them and resolve them, and kind of get in, learn what we're doing, and then we can go into healthy academic debates on what it is or what it isn't, but don't let it stop you from utilizing it, because it has worked. It does work. It works every day in our clinic. And you'll see that with these conditions, as well as other orthopedic conditions, patients get a lot of relief. So some of the characteristics are extremely painful lumps or nodules in the muscles or associated connective tissue known as fascia. They're classified as either active or latent. So active ones will reproduce local or referred pain or sensory disturbances. So when I hit that trigger point, the patient will say, oh boy, you're hitting it on my abdomen, but I'm feeling it right in the rectal area. How is that even possible? Or when you do that, I hit that trigger point in my adductor. Now I feel like I have to go to the bathroom. All of a sudden, I get a high urge. That's an active trigger point. So it's kind of sitting there, it's activating. It's probably activating all day long, sometimes all night long, causing them to have to go to the bathroom more often, waking them up in the night. The trigger point's sitting there, but we're perceiving it in a way that it's increasing urgency or increasing pain in the pelvic area. It's kind of activating. We also have latent ones that don't trigger symptoms unless they become activated. And so I think of them as they're sitting there and they're just waiting for their chance. So patient goes through a stressful time. They maybe were off for the summer because they're a teacher and now they've returned back to the classroom, which I actually had happen with the patient. She was doing great all summer. As the summer went around, went back to work, boom, was right back to the pain she was having before the summer started and she was treated. So they're latent, they're sitting there, they're waiting for their chance their time in the sun to jump in and do their thing. And they're just kind of waiting to get exasperated and cause a problem. Pain is often reproduced when the muscles compressed or stretched. So when we get in, we put some manual compression on it, or you stretch the muscle or the patient stretches the muscle. Often they'll feel the problem that they were having and that drove them into the clinic in the first place. And the myofascial trigger point is found within a top band in the muscle and typically refers pain in a predictable pattern when palpated. Typically a pattern that you can find on a chart. Now, I found many, many, many different charts and they do differ. Your best bet is to hit it on your patient and what they tell you is happening, that's where it's referring to. If I hit one in the abdomen and somebody's telling me, well, the rectal pain that they came in for is exactly what I'm seeing on that patient, I don't really worry about what the chart's telling me. I feel that that's a positive trigger point, even if that chart doesn't say, hey, that could refer to the rectal area. We know myofascial covers all muscles, it covers organs. It could impact every patient in a different way. When you research these, you will find that there's not just one chart, one exact way it can go. I've even hit, last week I had a patient right near her ASIS. When I pushed it, she got pain in her upper back, right in her thoracic area, which you won't find on a chart. It was actually on the opposite side of her body, but that's where it was hitting her. And she was, had full cognition. She didn't seem to be making any of this up. It was just where it hit. When I gave it some compression, when I did some myofascial trigger point, that resolved. But I won't find that on a chart probably, unless I make a chart up one day. Maybe I'll do that. We'll see. Okay. So muscles with trigger points are often weak, stiff, and have restricted range of motion. So that makes sense, right? If there's a trigger point, it balls up and it's kind of pooling on the myofascium, we won't see it glide as well. It'll often give restrictions in the muscle. We won't see range of motion be as good. It impacts the muscle's ability to create force and stops it from doing what it should do. This could be subtle, especially if the person hasn't had the trigger points for a long time. It's not that they go from a 5 out of 5 down to a 1 out of 5. It's just a little bit of a difference from their opposite side that you'll see in weakness. And sometimes it'll just be patient report. I don't know, it's weird. I feel a little stiffness in my shoulder, or I feel stiffness in my hip. And it won't be so severe, but that may be the start of what's happening with the trigger point. Frequently impaired circulation in the tissue surrounding trigger points and autonomic disturbances can be present. Myofascial trigger points can develop in any of the pelvic floor muscles and refer sensation to or pain to adjacent sites. So today we'll do some external to the pelvic floor, meaning we're not going to go internally. But when we do go internally, basically we have to go right around and look at every single muscle, because every single muscle in the entire body can have trigger points. And they can refer sensation or pain to all different areas. While I go back to charts, sometimes charts are good to help us see who the most likely players are. And on my slides down, I do have some of them referring to exactly where you'll find at the top of the charts. So for those of you who are, in the clinic and you only have a certain amount of time, whether it be an hour, 45 minutes, a half hour for your evaluation, we may not have time to do a full body scan trigger points. That would take a long time. It guides us to where the most likely players are and where we would maybe want to first start to look at that particular patient problem and to see if they have a trigger point. Sometimes it can go several sessions for evaluation. So I may find some on the first session in the abdomen, try to resolve those. The next time the patient comes in, relook at that. And then I may go to the obturator and turn to send adductors next time. It's not that we have to do everything on the first visit and find all the trigger points on the first visit. These referral patterns do not present in classic nerve or dermatonal regions, although characteristic referral patterns have been documented. So it is very different than dermatome charts. It's very different than looking for nerve pain. So, we kind of get to know sciatic nerve pain as you practice in the pelvic world. Pudendal nerve pain has a very characteristic pattern to it. These are different. Don't get confused into thinking, well, they're not following those charts. These are just going to be different. There are going to be different referral patterns. And while you can have nerve problems and nerve pain, you can also have trigger points. So you may say, hit something on the sciatic nerve and the patient has a problem with sensation or pain down to their foot. That may be the referral pattern of the nerve. You may also in the same muscle find trigger points that are referring to other areas. So you can have them at the same time, but they're not going to follow the same exact chart. The perineum, vagina, urethra, and rectum are common referral sites for pelvic floor muscles, but women may complain of pain in the abdomen, back, thorax, hip, buttocks, or lower leg. Men may too. The lower abdomen is a very common referral site for levator A9 trigger points, making it possible to confuse gastrointestinal, gynecological, and myofascial symptoms. So one of my main things I'll look at when patients come in is their abdomen. I'll look for this in probably 100% of our patients that come in for referral sites. It's a huge, huge area that we see problems with trigger points and myofascial. It will go rampant, it will go rectal, it will go vaginal, we'll see scrotal pain, we'll see incontinence issues just through the trigger points there. Sometimes I'll hit a trigger point in the abdomen and somebody will feel SI or back pain. They may feel a variety of different pain when you hit that trigger point. So just kind of be aware. But that really leads us down the path of knowing that it's trigger points. So what do we document? What is our assessment looking like? How do we grade these? We try to always strive for objective measurements. There's no real tool that we can scan over and say, "Whoop, you're a 1.3 on the trigger point scale. This is coming up on a machine. We can see it." It's a system that we tend to go 0 to 3. It's a 4-point system, 0 being one of the points that sometimes causes confusion. You'll probably find other assessment charts. As long as you're consistent in your assessment chart and what scale you're using, we're usually good to go on trigger points, whether you have to document for insurance purposes or just for purposes so that you know if they're making progress and you're the only clinician or other clinicians are involved in the care. We'll want to document something that could be somewhat objectively related. So we'll want to document where we found the trigger points first and foremost. Sometimes you'll want to say on the left side of the TA, found it in this quadrant and how many you found. Then we'll have to kind of say, was it 0, which is no pain, 1+, 2+, 3+, mild, moderate, severe. I know that gets a little wishy-washy. I mean, we're going by the patient saying, "Oh, that really, really hurts," or that I feel it, but it's not too bad. As you do these more and more, you get a little bit better with the feel on the scale, but you kind of need something in there to determine what it is. Assessment areas throughout the muscle are pressed, and assessments are done to determine where patients report them or react to it and how much is tender. So you rely a lot on your patient. And as we're treating and evaluating, you want to kind of have ongoing communication. How does that feel? Where do you feel it? What are you feeling right now? Is this enough pressure? Is this too much pressure to come up with your assessment? And then for treatment, there's several different techniques. There's probably many different techniques. I've seen people do all different ways. The most common one, though, is the ischemic compression technique, where it's simply a pressure and then an eventual release of that pressure. So while you're sitting there, have your left hand, use your right hand, and just put pressure on it. You can hold that for about 30 to 60 seconds. So if I was doing this with a patient, we'd be communicating. How does that feel? Is that too much? We don't want them in excruciating pain, but we need to trigger off a little response. So when you release your pressure on your own hand after those number of seconds go by, you'll see that it blanches, that it becomes a whitened spot. That's the ischemic compression technique. It just kind of presses down, you hold, remove it. And then what I would do with the patient right after is, give them a couple seconds in between. Okay, okay, now it's not feeling bad. Then I would go right back to the spot and give it a little pressure. Many times patients will say, that's weird. I don't feel it anymore. I don't feel the overwhelming urge to urinate. That was a trigger point. You helped resolve it. We reassessed it. Pretty good. We'll go on to the next trigger point. Another somewhat common technique is the George Thiel technique, was developed in the 40s. So you use a sweeping motion, stroking the length of the muscle. So if it was the arm, you would stroke down the length of the muscle. When I feel something, that's a trigger point. Sometimes trigger points I like to think of them as marbles or Tic Tacs, or even just the patient's like, ooh, right there, that's, the whatever pain they've been having. They'll stop, put pressure on that muscle till you feel it soften. Okay, that feels pretty good. Then whatever muscle you're doing, have the patient tighten it. So if it was my wrist, I'd say, okay, now hold up, tighten that muscle, hold, and then ask the patient to relax and let go of the tightening. That's just another technique to use for trigger points. Sometimes it's good to have a bunch of different tools in the tool bag. I think they used to say in PT school a lot, just a lot of tricks of the trade in case one really isn't working that well for that patient. You have another technique to use. And as you go to courses and go through them, you'll find that there's a ton of different ways to do trigger point release. But I think these are the two most common that I see when I go to courses or when we educate that clinicians use. A couple of things to educate the patient on: that they may be a flare-up before things get better. Over time, so I have a patient in the clinic, they'll feel better. Sometimes they'll go home and the next day they'll say, wow, it felt like you punched me in that spot. I warn them that may happen and that may be a normal reaction. And then that will get better. Usually then by the next day they feel a ton better. Just good to tell them that, because they will then go home and think you hurt them, or it's something went horribly wrong, or they'll say, I was feeling better, now I'm worse than I was and I should never do that again, which is not true. It's a common reaction. And over time, we can train the patient or the caregiver to do what we've done, so that they have something that when they flare up in the future, they don't have to necessarily always keep coming to therapy. It's, when you flare up, this is what I want you to do. I want you to give pressure to this trigger point, calm it down. I've had a lot of patients who that's very, very life quality promoting for them. I had somebody who was having rectal pain, went on vacation, was doing very well. He said, boy, I just started to get the first signs that it was flaring up again. And typically his vacations would be ruined by this problem. It would be that inhibitive to his life. Hit the trigger point, calmed it down, and he didn't go into a flare-up. So that's success. And anytime I sometimes see that person around, I'll say, that technique is really, I now never go into an actual flare-up. So I know exactly when it's happening. I get a dull ache, I hit it, I do about 5-10 minutes of it, and I'm good to go, which is a huge success. A couple things to remember: ease up on the trigger point pressure if it sends a sharp shooting pain, striking or burning. We want to go slowly at first. So we don't want to just jump right in, especially if a patient's never had this kind of work done. You may get the opposite response. You may get increased pain. They probably won't like you very much. They may never come back. Don't poke, don't bruise. A lot of beginning clinicians, as they go into lab, they start just trying to poke around. Is it here? Is it here? That's very uncomfortable for a patient. We like to go in with a flat hand first, diffuse pressure, and then we get a little more drawn into that area so that we could do our trigger point work. Just something to remember. Have the patient breathe deeply. We know that breathing deep causes a calmness in a person. It calms down the vagus nerve in their system, keeps them overall in a state of not overreacting, because at first they're nervous. You're poking around, might be ticklish, they've had pain, now you're in there poking. We want their system to be as calm as possible. And pushing too hard too soon may be counterproductive. So if I get in and I poke real hard and they jump off the table, now I've set them into pain. It's horrible. They've already had maybe 10 years of chronic pelvic pain, and now I've really shot it off the charts. So it's not really our goal. Some tools you can use. So today I'll use my hands. Hand over hand is a good way to do it. So essentially you'll see I'll go kind of hand over hand. You could also, when you get in enough, a supported thumb, sometimes you could use your other hand over your thumb or a thumb over thumb position. Although we have used and patients use things like massage sticks, foam rollers, tennis balls, myofascial release balls, which a lot of my patients will just buy online. Once we know where the trigger point is, how it's responding, how we can kind of calm it down when it flares up, then we highly encourage patients to learn these things, to do them on themselves. And sometimes it just is helpful for them to have tools. I mean, depends on the condition of their own hands. I've had some people with arthritis issues where they'll say, "Gosh, like I can't push as hard as you can. I can't push down. It's actually hurting my hands." If there's areas that they can lie on a ball, so I'm kind of thinking specifically about glute trigger points where somebody could put the weight of their body onto the ball, lie on it, do 30 to 90 seconds of trigger point release while there's just sustained pressure. It's very, very helpful, and they don't have to go poking around, especially if it's a point that it's tough for them to reach and get on their own. I have some people with shoulder issues that if I said, go around and get the glute, their shoulders aren't very, very mobile. Maybe they're a little older population. Maybe they have arthritis. They can't get to them. So all these tools are things that they can use to help. Then after you do the release, stretching is something that is very highly promoted because you've released that. So we've released the trigger point, which is great. But now we want to try to get that muscle back to its normal resting state. So you've taken something that's balled up, is how I think about it, and you've released it to let the tissue lengthen. Now the patient can go into, or you can do a stretch on the person to get normal length again. And this will be something they'll have to do over and over. It's not a one and done. It's not, I would say it's not a magic trick. It's not like I released it and they're good to go and I've lengthened it and it'll never happen again. The body adapted to having trigger points. So we have to kind of attack them early and often, I always say, and get the patient to do this. It's very difficult to stretch a muscle that has a trigger point due to the chemical telling the muscle to contract. So they must be first released, and that stretching after retrains the affected muscle to go back to its resting state. It has a muscle memory that will want to go back to that contracted state, especially if the trigger point's starting to develop again. So patients sometimes in the beginning will have to do stretching 6 times daily, then 1 to 2 times daily may be needed for maintenance after that. There's no true just this is the actual protocol, but we'll just keep in mind in the beginning, they'll want to do a lot of stretching. And then as we go to maintenance and they're feeling better and better, they can reduce down that stretching because nobody wants to spend their whole life stretching, right? It's like 6 times a day for the rest of my life, maybe unrealistic for a lot of people. They're highly motivated in the beginning, so they'll do it in the beginning. And once the trigger points have been resolved, they'll kind of fall off doing that much and then they'll fall off totally. So sometimes I can get somebody down to, hey, just try to do this once, get up in the morning or right before you go to bed, do these 2 minutes of stretches and keep yourself in a maintenance pattern. All right, now on this slide, I just wanted to reiterate the fact that trigger points can be internal, vaginal, or rectal, and or in areas referred to as external. Have on the slides, of course, we won't be going over all these slides, but they have some referral patterns on them. Once you kind of see and know and start practicing, you can go through all your slides and just work on the various muscles. I really wanted to, as I've been going on and on about, is show you a little bit on what to do with rectus abdominis or the TA. You'll see on my slide, this could refer as mid or low back pain, urgency, urinary urgency. I've also seen fecal urgency come from this area, rectal pain, vaginal scrotal pain, but there are a ton of other places this will refer to. So I'm going to demonstrate how to kind of assess, how to treat, and then we'll have the patient go into the stretch that we commonly use for this. My husband, who's always a good sport when I'm teaching pelvic things, has offered to be the patient. So I'll have him get right up on the here. So you can jump up there, Jack. Just want to make sure the camera hits him okay so you guys can see what's going on here. Now zone in right around his abdominal area, and I'm going to sneak around the back of him. So what I would typically do is I would have already talked to him about what trigger points are. I've educated him. Then I'm going to go through, and I'll just do this side of the muscle. I want to go through the length of this muscle and start looking for trigger points. And again, I don't want to poke down on him because he'll be very unhappy and may leave my clinic. But I keep a flat hand. You can go hand over hand. So a nice flat hand with a sustained pressure. You can go top to bottom, bottom to top, left to right, right to left. I don't really get hung up in the exact pattern. It doesn't really matter. I just want to go through the entire muscle area, the length of the muscle. Start with a very soft pressure at first, and then just draw a little deeper into the muscle to see if you feel marble, tic tac, hardening, or if the patient says, oh gosh, when you hit there, I have to go to the bathroom, or when you hit there, I'm feeling that pain in the scrotal area. Note how much pain or discomfort they're having. So I'll say, is that a lot of pain, or is that a little pain? Is that the worst pain you've had in your life? They'll tend to tell you like, oh my gosh, that's awful. That I would put as a 3+. I just feel it a little bit. I might say that's a 1+. I'll note where these are along the muscle area. And I won't make you watch an entire session because you guys have things to do with your morning and your night, depending on where you are. But you would assess through, and the whole time I'd say, anything there? Tell me when you feel anything at all that you feel. Normally in the beginning, they'll say, I just feel pressure if you're pushing. And then once you hit one, they'll kind of get it. They'll say, oh gosh, that's what I've been feeling. Then once we've identified where these are, I'll go through the entire, both sides of the abdomen. I'll go up and down. I'll go right down to the attachments. Then we'll start the treatment. So say I found one. Let's see, I'll put one right where the camera can see a little bit better here. Say he was saying it's right here. So I think you guys can kind of see a little more of my hands there. I'm going to do a hand over hand. Now I've gone from a very flat hand to I start tilting it more towards the trigger point. Then I'm going to build in pressure gently at first. I'll say, are you doing okay? You're okay. You feel it a little bit. They'll usually say, if I feel that, is that too much? You want me to draw pressure? No, that's okay right there. And then once I hit where it's a little uncomfortable, not that anyone's run a clinic uncomfortable, kind of just hang out for maybe 30 seconds, 90 seconds. How are you feeling? Is it easing up at all? The normal course will be like, oh gosh, I really feel that. It's not as bad right now. And then often they'll kind of say, I don't really feel that much. Sometimes when they don't feel much, I'll go a little deeper into it to see if it's just resolving that there's something left of the trigger point. Then after that time frame, I'll release the pressure. I'll give them a couple, maybe a half minute or so, say, okay, you okay? You feel anything? Often they'll say, no, I'm fine, I feel good. I'll go back to that trigger point and I'll give it the same type of sustained pressure, maybe a little quicker this time, and see what happens. So if he says, that's weird, I don't feel it anymore, I've known that we've run that trigger point for. If he still feels it, I may get a second round of pressing down, try to resolve it completely. And as we resolve that one, I'll go to the next one. So if I had another one here, I'll hit that one and we'll go through the abdominals. If I'm going to do the thumb over thumb or sustained thumb, I would put the thumb here. You could put your other hand over the thumb and give it the hands are going to suffer and you'll have some problems. So as my thumb's on him, I'm trying to keep a flat thumb and full pressure. I don't want to hyper activate my thumb and put pressure through it because our own hands then will put us into a therapy for our hands if we keep doing that over and over. So at that point, after I've gone through all of the points in the abdomen, I'll have him now flip and we'll do a common cobra stretch. So this is taking the muscle where we had the trigger points and lengthening them. So I'll have him come up. Go ahead, come up. May have him for 10 seconds. A lot of times I'll combine this with the deep breathing. So I'll have him go ahead and breathe, relax. Remember, we want big diaphragmatic breaths, not just chest breathing. So it's the umbrella of the ribs and the stomach coming out. This should be comfortable for the patient, by the way. They should feel like it's a relaxing stretch at the end. Usually I'll have them do about 5 of them, reset the muscle and get them kind of back to normal. Then this was our session. I would send him home with, okay, Jack, now I want you to do that stretch 6 times a day, 5 times, get up in the morning, get in a pattern of get up in the morning, go to the bathroom, do your stretches. At night before you go to bed, do your stretches. So that's 2 already. During the day, do your stretches. I may even give him the standing type of extension stretch because when he goes into the office, it may be hard for all of our patients to give him options on stretches and get him to be compliant with that. The next time he comes into therapy, then what I'll do is reassess those trigger points, see if they've resolved, see if any other ones have popped up in the abdomen, and we'll kind of repeat that. Another one I want to do is the obturator internus muscle. So this is a muscle deep in the pelvic floor. I have it on the slide. It's in the lateral part wall of the pelvis, found in the superior inner side of the obturator membrane. This one is one you can do internally for people when you're trained as internal, but it's also a fantastic one to do as an external trigger point. This can refer to the urethra, coccyx, posterior thigh, give a feeling of fullness in the rectum or vaginal pain. So how do we do this on a patient externally? I'll move the screen down. And we're going to catch this muscle. You could see a slide right around the sits bones that you have to sneak hand in there and get to the muscle. So I would expand him out a little here. Draw your hand up till you feel the hard stop of the sits bones. Tuck in to that bone. So you should feel a hard stop of the bone. Now you're tucking your hand inside of that area and you're looking for trigger points. If you're not sure you're on that tendon or on the membrane of it, a real great trick to do is have the patient bend the knee, then have them push into your hand to trigger. So go ahead now, push into my hand, and you'll feel the tendon of that muscle jump into your finger. And then you know you're on the obturator internus muscle. Then I would do the same thing. I would get in. This one is a tough one for some people in the beginning because they tend to be pokey, but remember, try to then flatten your hand a little, get in, draw in pressure, talk to the patient, see what they're feeling, see what you're evoking, and then the same thing. When you hit one and you're ready to treat, hold that for 30 to 90 seconds, see if it's resolved, go back in, see if they have any symptoms. You can repeat if they do, and try to get that trigger point to resolve. This one, sometimes clinicians really like the thumb method where they come in because it's a little more on point. I will warn you, patients, if you go in a little too much, you're going to cause pain, discomfort that may not even be the trigger point. So just come in gently, get your other hand on top of it, and give it that pressure. Then after we've resolved the trigger point, remember we want to go into a stretch. So once I have a patient here, then I'll just go ahead and stretch that hip rotator. Point where they feel a stretch, we'll hold it maybe 10, 20, 30 seconds. And then release and repeat about 5 times. And you can also send them home with that stretch too to resolve that trigger point. And that's kind of the basics on any of these trigger points. We can use those techniques throughout. So I've got on the screen here the adductor. It's the same concept. You span the whole muscle. You look for the trigger point. Flat hand in the beginning. Note where they are. Note how intense they are. Go into treatment and then stretch the muscle out at the end. Okay, thank you, Jack. On the rest of the slides are some of the common ones. This is not all inclusive, of course, of every single one. We'd have to have a huge slideshow. But here you'll see, as we're getting a little more into the exact areas, you'll see the superficial layer of the pelvic floor. These are external. These are all things that can be hit without actually entering inside the vaginal canal. There's bulbal cavernosus, ischiocavernosus. All of those are muscles that we'll see, especially in female vaginal pain, vagissimus, that you go in. We train patients to do this on their own, depending on, of course, your own comfort level. Well, men and women, this one is, I believe, a female pelvis there, but those are our muscles that we'll see problems with. I put on here gluteus maximus, medius, minimus, iliopsoas, lateral obliques, paraspinals, pectineus. So here are some that you can play around with, practice on your friends and family. See if you can locate them. You may be surprised that even in people who aren't complaining of symptoms, you'll find some trigger points on, kind of work on technique. Get them to be brutally honest in the beginning if you're being too pokey or too anything, where they can guide you a little bit and let you know how much pressure is normal, how much is uncomfortable, and develop your skills in trigger point. So I'm going to try to see if I can take that down and see questions coming in. So I see here, what about breathing patterns of a patient during trigger point release? So during the trigger point release, you'll want the patient to breathe one of the principles of diaphragmatic breathing. So remember, we want to avoid upper chest breathing. They should fill up the ribs, the abdomen should rise, and the ribs should flare out. They should just take a nice, natural, easy breath in, and then let it release. Sometimes people will say at a 5-to-5 ratio. I've heard a 5-to-3 ratio. So breathe in for 5 seconds, out for 3 seconds. The effect of that is a calming effect on the patient. They're already in a system that's a little hyper-driven. Trigger points are a reaction to stress or a reaction to feeling a little more hyper. So that'll help calm their system down, because you're going to go in and evoke some pain. So we want to be starting with a calm type of system. How often is reoccurrence? That's a really great question. It's kind of different for every person. Well, we'll see reoccurrence of trigger points happen at times of stress. So there's good and bad stress, but the system doesn't know the difference. So they may be planning a wedding, and that's good. They're happy, they're getting married, and yet they're having stress. We may see trigger points. We may also then see them come back during bad stress. So we had a death in the family, everybody's sad, I'm going through so much stress. We'll see them reoccur. We may see them reoccur just because they've started a new exercise program, or they've returned to exercise. Or sometimes the patient can't even tell you why, they just will reoccur. There's not really a common duration or frequency of the return of them. I've had people that did well for 6 months and it popped up. I have people that maybe every week they're popping up. Can we do this for women who are pregnant? Absolutely. You can absolutely go in and do trigger point release on women who are pregnant. There used to be a thought that there were points that would put them into labor, one being the adductors. I don't believe that's a thought anymore. There's also a point around the ankle that used to be thought to put women into labor, although I think that's been dismissed in the medical community. So does mobilizing the lumbar or the pelvic area help release trigger points? It can. It can be that you'll have to release the trigger points before you do your manipulation or mobilization, because trigger points, remember, will pull on the myofascial and cause a tightening in the area, and things won't move as well. So sometimes when you get in to do that manipulation or mobilization, and you find that it's just, you keep saying relax to the patient and they keep saying I am relaxing, and you're having that fight with each other a little bit, you may want to look for trigger points and release them first. Then the tissue naturally relaxes better and you can go in and do your mobilization. Can we release trigger points of rectus, pectineus, obturator, internus through dry needling in a single session? You could with dry needling. I'm in a state, unfortunately, in the United States that physical therapists are not allowed to dry needle, so we don't dry needle in our clinic. But I know that people who do dry needle report that it's an effective tool, definitely an accepted tool. And I'm hoping that in Pennsylvania, they change their regulations, which they may or they may not. We've seen things go back and forth that we can get into, dry needling for the pelvic floor. So how do you release the levator ani? That's a good question. One, it could be internal. So you'd have to go inside either rectally or vaginally, hit what would be reported as your classic trigger point signs and symptoms. And you can give it the same kind of pressure. Now, a little more difficult because you're not going to get two hands on a patient and be able to manipulate around. You may end up a little more pokey. So that's a skill in itself to get in, get on the trigger point and release. You can also try with the patient prone around, you drop off the side of the coccyx, squish into I would say the squishy tissue, but it's perineum, and you can do the same techniques and look along the perineum for trigger points and do the same type of thing where you're pressing in. Where would trigger points for urgent continence and mixed incontinence be? I'm going to tell you they can be almost anywhere. The common places we see them are the abdomen, the obturator internus. We did those two today. Adductors, super one. Although I've seen my fair share of them around the piriformis, right around the coccygeus that sits around the coccyx. I've seen them come from multifidi in the low back. And I've seen a couple come from the lateral side of the hip and the tissue there, often in patients that have a history of hip problems, maybe like labral tear or hip replacement. You'll hit them and you'll be able to replicate what they're having and resolve that. What else do we have here? Try to scroll up so I don't miss anybody's early ones. So in internal trigger point release, that's a skill that you either have to practice or go to lab, and there's, holes to look for. But essentially you enter in the vaginal canal, rectal canal, give pressure on the tissues, give pressure on the muscles inside of the person. They'll report kind of the same things that they're reporting with the other trigger point things. Ooh, that's exactly the pain I've been having. You give it 30 to 90 seconds of pressure. You can do exactly as we did there in lab. There's sweeping do on it. Get the symptoms to reduce down, go back in, give it the same kind of pressure. If they're no longer having that, you've kind of released that trigger point, and then you kind of move around in a clock. Usually people in a clock-like pattern. There's layer 1, 2, and 3 of the pelvic floor. So we go a little more superficial, go around the clock. Layer 2 is a little deeper, go around the clock. Layer 3 is deep, deep, deep within, go around the clock of the pelvic floor, determine where they are, kind of do the same techniques. Um, can these techniques be done on women during menstrual time? Absolutely. There's no barrier to doing it at any time during menstruation. We actually continue to do them. Believe it or not, internal is still done on somebody during menstruation. The only time we would say no is really patient discomfort with it, but there's nothing about menstruation that would stop you from continuing with this or a patient continuing with it during their menstrual cycle. How often should we do myofascial release? Daily until it's released. You you could do it. There's no contraindication to doing it daily. So I like in the beginning, I'll see a patient in the clinic, we'll do it, send them home with the see the next day they're going to, I always warn them, you're going to be a little more sore. You may have some symptoms, may feel like I punched you in the tissue. Hopefully they'll come in the next day into the clinic. If not the next day, I'll reassess. We may hit them again, see if they're there, have them continue stretches at home. Eventually, if they're having problems and we're resolving them, there's no communication to them learning them and doing them daily at home. Now, where I am, we don't see to happen. We've a lot on insurance, and they aren't too keen on somebody coming 5 days a week. I think would be great, but for trigger point release, so they can do it every single day. When they get in and go off on their own, I'll ramp them down. I'll say, you've been doing this 3 times a week. You're doing great. You haven't had a symptom in a month. Try it 2 times a week. If you're great, try it 1 time a week. If you're great, not having any problem, try it every other week. I like the least amount of work for the highest amount of payoff, so they can ramp down on it and just get them into a pattern where they may not need to do it at all until they flare up again, and then they can jump in and do it. So that's kind of the goal, that they get it have it under control. It's a part of their past, and they know what to do later if this thing creeps up again and they're having problems. What would be the duration of one session? Well, it depends how many trigger points you're going for. I've done full 60-minute sessions hitting various triggers. I've done 15 minutes of trigger release. They're doing well, and we may move on to other things in their program that day. I would say that the duration of the trigger point session in the beginning will be longer. And then as they get better and better, the trigger point hands-on part will be shorter and shorter. So if I was doing abdomen, obturator, internus, and adductor all in one session, so we're talking about 2 adductors, a full abdomen, 2 obturator, internus, that may take the full 60 minutes between hitting them, stretching them, reassessing them. Then as they come in and they're getting better and better, I may only spend 10 minutes on the abdomen, 10 minutes on the obturator, internus, 10 minutes on the adductor. And then we may go into other things in their program, like strengthening or some of the other stuff we have in the program. Then it may be 5, 5, and 5. Then it may be just a matter of me reassessing every session and moving our things forward to getting them towards independence, handing off some of that to them. So I may one day say, oh, you're good. What I want you to do now is try those abdominal ones on your own at home, and then come back and tell me how you're doing. And then they may come into barriers. We may take some time on patient education and get them to be able to do them on their own. So it's kind of a ramping of them over time. Let's see. In which conditions can we use these techniques? Honestly, with these, you use these techniques with any type of pain, any type of incontinence. And then really, don't get too hung up on diagnosis that they're coming for, although it's helpful. I get more thoughtful on, are the trigger points, are they what's contributing to the symptom that they're having and they're coming to me for? And by treating them, are we reducing that symptom? So we could probably rattle off different diagnoses at the top of our head that would be appropriate for, and that would still leave out 400 different diagnoses. It's just about if the tissue has a trigger point, if they'd benefit from trigger point myofascial release. So you could do trigger point and then right into myofascial release techniques to further free up the tissue. And if the person then is benefiting and their symptoms are resolving, you're on the right track. You can continue on that. So don't be too concerned about the different diagnoses, although I know, that helps us package what we're doing. But whether it's urge, mixed, stress incontinence, any kind of pelvic pain, anything around that area, if you're finding trigger points and they're contributing to the problem that they're coming to you for, then you're good to go on treating them and trying to resolve them. What about contraindications? Can we use these for weak or inflamed muscles? So absolutely, you can use these for weak muscles if they have trigger points. So remember, trigger points can cause a weakness in the muscle. So if a patient is having a weakness in the muscle, you can scan them for trigger points. If you find trigger points, then go into trigger point release. If you don't find any trigger points and they're weak, there's probably other reasons why they're weak. So we wouldn't want to go in treating something that's essentially not there in order to gain strength. We would look towards other strengthening problems or problems that the patient has that's contributing to the weakness that may not be trigger point related. But absolutely, I think that it would be worthwhile that if somebody is having weakness and it's not resolving, you can quickly, easily, and non-invasively, and really without worry that we're going to cause anything negative, scan through the muscle, look to see if they have trigger points, and then look to resolve them. Is it helpful to use heat or hot packs before compression, or is it better to release the trigger point in external areas? I will always start with just my eval and treatment without using any kind of heat or ultrasound. Definitely, though, in patients, I've used heat for treatment sessions. So if they're having some issues with pain, I'm not really getting them resolved, feel free to go ahead and see if heat helps resolve that trigger point or help soften the tissue around it so that we can get in a little bit better. There's also settings, and that's kind of beyond what we're doing today, but that can help use ultrasound following trigger point release to get the tissue to somewhat reset to not have the trigger point. So there are many things surrounding that can help. E-stim sometimes can help before or after, depending on the goal of the tissue. Could I say a good book for pelvic floor rehab? There's a bunch out there. There's one called A Headache in the Pelvis. Um, that one focuses a lot on your male population. There's Pelvic Pain Explained. There's the IC Solution. There's books that were written by Travell on trigger points just in general. I think that those you'll find a lot of good trigger point charts in. And you could just, instead of right on to an internet search or Google search of pelvic floor trigger points, and you'll come up with a ton of information on trigger points, how to release them, different options to release them, where you'll find them and where they may refer to. Sometimes you can end up with too much information online and on books, but when you first start out, just feel free and look at different answer for hot pack or compression or release points in external areas. So you can feel free to use hot packs. I would first evaluate and treat without them. And then if you find that maybe the patient isn't responding as you hope they would, you can go ahead and try to use a hot pack before your next trigger point session. That tends to release the tissue and relax it around trigger point and becomes a relaxing feeling for that patient. So they overall have a relaxing with heat, and then it may help you. Also, you'll find that ultrasound sometimes can, and that's sort of beyond what we're doing here, but if you look up ultrasound, different parameters, sometimes pulsed, sometimes heat, depending on what you're trying to do, can help either relax the tissue before that or afterwards help reset the sarcomeres in the tissue to lengthen and release.